Morning, everybody. Welcome to our webinar. It's just 1 minute before 8 o'clock, so we're going to go ahead and get started. My name is Kate Elliott. I am joining you from my office this morning. We're going to have a webinar on brief intervention skills for primary care clinicians and behavioral health consultants in the primary care behavioral health model. Before we get started with our presentation today, we'll talk about just a couple of logistical things. Since we have so many people on the line, everyone is and will remain on mute throughout the presentation. We do have a couple of chances for you to chime in with your thoughts on the presentation topic. When those opportunities come up, there's a chat box in your GoToWebinar control panel, and you can use that. We do encourage you to send us your questions throughout the presentation. We'll hold those for a Q&A at the end, but you can go ahead and send them throughout through the questions pane on your GoToWebinar control panel. The one question I can anticipate from everyone is about the webinar slides. They will be available on the Institute website along with a recording and another document that our presenter will be talking about today by 5 o'clock today. In addition, you'll also get an email from GoToWebinar that lets you know when those things are up and ready, so never fear. Before I hand things over to Dr. Robinson to get us started, the Institute is a public-private partnership launched in 2012 with the support of the Oregon Health Authority and Northwest Health Foundation and managed by Quality Core. Together with the experts we partner with, our goal is to get primary care practices connected to a broad array of technical assistance as they work towards the patient-centered primary care home or medical home model of care. We want to serve practices that are at all stages of transformation and help build capacity and create alignment to support ongoing transformation and quality improvement in Oregon. One of the things we heard was behavioral health integration was a big topic for folks working towards the PC-PCH model, so that is what brought you this webinar today. We encourage you to visit our website, which is www.pcpci.org, to access resources, including previous webinars. We do record them all and throw them up on the website so that you can view them at any time, or you can share them with colleagues who maybe weren't able to log on this morning. Like I mentioned, the Institute works closely with the Oregon Health Authority PC-PCH program. The PC-PCH model of care is defined by 6 core attributes, each with specific standards and measures. That's how the state is able to recognize people doing excellent work in Oregon and recognize them as primary care homes. You can review the standards, which there are updated 2014 standards now available on the PC-PCH program website, which is primarycarehome.oregon.gov. All right. I am very pleased to hand things over to Dr. Patricia Robinson, who has been working with the Institute on a series of behavioral health integration trainings. Dr. Robinson has explored integrated care from the perspective of a clinician, researcher, trainer, and healthcare consultant for more than 20 years. She's worked on behavioral health integration with providers across the country, including the Bureau of Primary Care, the Air Force, the Navy, Kaiser Permanente, and city and county health departments. She has literally written the book on integrating behavioral health in primary care. And I'll let her talk a little bit more about her experience, but we're very pleased to have her with us today. And we'll let you take it away.
Thank you, Kate, for the warm introduction. It's great to be with everybody today and to have a chance to introduce some folks from Oregon that I've been working with that are in the primary care clinics, and so that's part of what today. But also I'll be talking with you today about, Kate, I'm not advancing for some reason to the next slide, but I'll be talking with you today.
You'll get there.
Okay.
Try clicking on the slide one more time.
Okay. All right.
Oh, there you are.
Yay. Here we go. Got it. So, yeah, today I think we have about 100 people listening in across the state, And I'm not sure how many have been to any of the previous trainings, and so I'm going to do just a very quick introduction of the primary care behavioral health model, which is a very specific model for health providers into primary care clinics. Then I'm going to provide a self-assessment tool and encourage you to use it to kind of look at your skills and knowledge for working in a brief way with patients. Then I will kind of, as we go through the 21 items, I'll describe kind of the highest level of competency in each of the areas to give you an idea of something you could aspire to. We'll complete today with you developing a career development plan and kind of thinking through who might be able to support you in pursuing this, where you really focus on 2 areas that you want to get better at. Lifelong learning. So, no, why? Okay. Just a few key terms. You'll see the here. So it's press once and wait. I'm like a very energetic, sorry guys.
Yeah, I was going to say, we're going to have to take your caffeine away. Oh, looks like you're...
I'm on the right one now, Kate. Okay, so just a few key terms you'll see in the presentation today. First, you'll see PCC. This is the abbreviation we're using for primary care clinicians. So that's any primary care provider. And this is the person that retains ultimate responsibility for patient care, so the leader of the patient-centered primary care home team. You'll also see BHC, and that's our abbreviation for behavioral health consultant, which is the member of the primary care team that has expertise in behavioral health care. So this model, primary care behavioral health, or PCBH model, really started with research studies, and then through many, many years of working with different systems, we figured out, how do you disseminate this? How do you really transform primary care or reinvent it so that it's not just based on a research model, but it's really based on a team where everybody is playing together. So, of course, the BHC comes in. The BHC is a fully integrated member of the team, but works as a consultant as opposed to a psychotherapist. So they consult on any area related to behavior change. Behavior change in the service of helping the patient improve, maintain, and sustain good health. Health meaning mental, physical, and social. So the behavioral health consultant basically delivers 2 services. First, brief interventions, which are one-to-one interventions, but they can be family or couple interventions. They're all 30 minutes. However, that being said, this is a model that says 10 minutes is better than sending somebody away for a future appointment. So on average, 15 to 30 minutes, and often on the same day as the medical visit. The typical initial intervention includes an assessment and an intervention. So it's not just assessment, but it's behavior change from the get-go. Pathway services target members of specific populations that are of concern, either because there's a lot of people in that group or because of the way that they're impacting the healthcare system, and always because we want to improve our outcomes. So in pathway services, what happens is the role of the being consultant is defined by the pathway, and in such a way that's bringing more evidence-based care to members of that population. So pathways can involve assessments, individual visits, and group visits. Either brief kinds of group visits like workshops or a class series, or ongoing visits, as in the case of group medical. So that's just a very, very brief description. Kate, you want to say a few minutes about resources on the web?
Yeah, so the Institute recently hosted 3 week-long trainings on behavioral health integration, and in that process we were able to give toolkits and a series of training materials both on implementing the primary care behavioral health model, so a program manual, an organizational readiness assessment, a referral barrier questionnaire that BHCs can use to inquire about why they are or are not getting referrals from their primary care clinicians, measurement tools, sample chart notes, and sample forms. And we're putting all these materials together to make them available through our website, so not just to the folks who attended the in-person training, but they'll be available through the web as well. And then also tools for behavioral health intervention, so tools that BHCs or others could use with patients. So those materials are still sort of in production. We will send an email out to our email list once they are ready to go. In the meantime, there is a webinar that is more detailed information on the primary care behavioral health model that Patty just went over super briefly. Also during those 3 weeks of training, we inquired and got applications for and subsequently selected 3 organizations to serve as best practice sites. And these sites are going to receive individual coaching from Dr. Robinson in the coming weeks and continue to serve as examples to other clinics that are looking to adopt the primary care behavioral health model. 2 of the 3 organizations were able to join us today to share some of their experience with the model, answer some questions so that we hope will help make it clear for those who are out there listening today, and as well as to talk about the competency tool Dr. Robinson will cover later in the webinar. Before I turn things back over to Patty to talk with these folks, I wanted to introduce them. So first we have Brian Chow, who is a licensed psychologist in the state of Oregon and currently a behavioral health consultant at Rosewood Family Health Center in Southeast Portland. Dr. Chow graduated from George Fox University and currently resides in the Portland metro area. Brian Sandoval is also joining us, also a licensed psychologist, and is the current program manager for primary care behavioral health at the Yakima Valley Farm Workers Clinic. Prior to his position there, he was employed at Providence Medical Group and completed a postdoctoral fellowship in primary care at Access Community Health Centers in Madison, Wisconsin. Brian currently resides in Damascus, Oregon. Jackie Travis is the behavioral health consultant at Peace Health Medical Group, Eugene, working to support primary care providers to improve access to behavioral health care interventions at the time of the medical visit. She has more than 25 years of inpatient psychiatric care experience from a care coordination perspective and has focused on integration of behavioral health with primary care for 5 years. She has a master's degree in education, counseling, and guidance from California State University with postgraduate training, including a recent certificate from the University of Massachusetts in primary care behavioral health. We are really pleased that they are on the line to share some of their experience after training with us today, and I'll let Patty go ahead and ask them some questions about that.
Thanks, Kate. After foundation training, the training we did like in September and October, we call foundation training, the BHCs that participated have gone back out and tried to make changes in their system and practice some of the skills that they learned in foundation training. And so I want to ask just a few questions about the experience they've had. And the first question is, what part of the primary care behavioral health model appeals to the reality of your work?
Well, here at Rosewood, I've worked in the outpatient setting before, but being at Rosewood in Southeast Portland, it's really hard for patients to get into care. Outpatient clinics are swamped, or maybe patients have had negative experiences in the outpatient setting. And so the integrated model allows me to really help a lot of patients when they need it during the visit. And our phrase here has kind of been striking while the iron is hot. And if anything, it's actually helped the patients navigate the outpatient system more effectively because we kind of have an insider here who can direct them to where they need to go if they do need outpatient services.
So it sounds like the same day our warm handoff is really working for you at Rosewood.
Yeah, all the providers have really appreciated it, and we've documented the impact that the integrated model has had on the patient care.
Fantastic. How about you, Jackie?
Yes, hi there. Well, one of the things that I really appreciate about this model is a problem that I see really in the relationship between patients and their care is that they come in and they're concerned about a health problem and they want the doctor to understand it and they want the doctor to fix it. You know, with pain and depression, all manner of things that they present with. And they want pills and procedures and expensive referrals and a lot of other things that aren't necessarily going to be useful to them in the long run. And we see this over and over, and it causes frustration and pain for them. But the behavioral health consultant is able to query the patient much more deeply about what's important for them in kind of a broader sense and try to approach the problem from a standpoint of offering them skills that they can use that will assist them in achieving better quality of life and support simple skills and assist them in an ongoing way to discover what supports, what barriers, how they can reach some of their goals. I got really snagged by this process when I came across the definition of the behavioral health consultant as far as what I'm supposed to say about who I am, that I'm supposed to say, quote, after about 15 minutes, we'll start developing a plan to improve your quality of life starting today. And that really grabbed me, and it felt really scary to think about saying that to patients. But you know, I'm seeing that's my responsibility to find something today that's going to make a difference to them when they leave and make them feel understood, and as if their problems, you know, are things that we can help them with, perhaps in surprising ways that they didn't expect. Getting together with the patient and discovering what their motivation is, listening to the barriers, and building a relationship that is keyed into the community of care that they experience between the medical assistants who are so important and the doctors and others, and myself being embedded in that group, that team that's trying to help them experiment with new skills to get, you know, make some progress on their pain or their problems or their depression.
Fantastic. That sounds awesome. I think we're going to cover later on today the importance of that introduction and suggesting to patients that we can help right away and that change is possible and that long-term psychotherapy is not a prerequisite to improving your functioning, that you actually can function better with just a little assistance at the time that you need it. So how about progress in terms of influencing PCCs? I know the VHCs in foundation training got 4 days, and the PCCs and nurses got 1 day. So really part of your job was to go back and try to share what you learned, because it's so important that we take a team approach. How's that going?
This is Brian over at Rosewood. It's been going well. We've been able to both directly and indirectly support patient care. So I've noticed that we've had some systemic changes, for example, helping the nurses and the providers set healthy boundaries with maybe high utilizers or pain-seeking patients. We've also been able to promote more referrals for health-related referrals. So instead of just mental health issues, we've been able to help patients with self-management issues regarding diabetes or hypertension and chronic pain.
Okay, so able to influence them in terms of broadening the types of patients that they're referring. I will say it's quite typical when a behavioral health consultant first starts working in a clinic that the primary care clinicians refer mainly patients with anxiety, depression, and over time I think they learn about the fact that BHCs are also trained to help with headaches and chronic pain and hypertension, as well as a variety of chronic diseases. So, Jackie, anything to add there in terms of, I think you were kind of covering that. But.
Right. Primary care physicians, we all know who work with the PCCs are really overwhelmed by the pace of the work and the demands that are placed upon them in the system currently. And some of the most persistently challenging patients, like chronic pain, health behavior problems, unremitting depression and anxiety, people who are crying in the office and overwhelmed by the economic status and social relationships in their lives, the doctors sometimes feel ill-equipped to really manage these people. Partly it's a time crunch, and partly it's kind of a focus and a set of skills that they struggle with. I have a particular young doctor that I work with, and he is so reinforcing to me. His MOA will call me, and within about 5 or 10 minutes, I will walk into his space, and his face lights up. His body language is welcoming and excited to see me, and he just, does the right things about taking me into the office and saying, Jackie's working with us, and she's going to help bring some additional skills to this issue, and he's so happy to have me help him out, and for him to know that I'll be, doing this brief work, that I'll get back to him on what I did, and that when these kinds of issues that are especially difficult for him to just kind of cope with in the time frame he must try to do so, that I'm going to be right there and available to him with a phone call. And it just, it's extremely satisfying to me to have that sort of response. And he really does a super job setting the tone for the patient's expectations that I am going to be helpful. So I have a number of doctors, I think, because they're so ready for a break in the pressures that they're under, that they're just really reaching out for what we can come up with, and it's experimental.
Excellent. I'll just point out to our listeners that in the manual and the manual appendices, there are support materials for PCCs and nurses, including scripts for what to say when referring to the BHC, so that you really help the BHC get a good start. I'll also just add that I've trained in this model all over the world, lots of PCCs, and I've never had a PCC say, no, I don't want that. Once they understand what the model is, they're always like, yay, this is what I've always wanted. So what are some of the challenges at this point, and how are you addressing them?
For us, it's been related to PCC workflows. At this clinic, a lot of PCCs have different workflows just based on the nature of their panels. And so kind of to, I guess, summarize it, finding that balance between structure and flexibility, which I think is both a strength of this model, that it's open and you can adapt it to each clinic and patient population as needed, at the same time still providing a pretty solid grounding structure. And so one challenge we're working on right now is going to just establish clinical pathways, and that's where we are. That way we can better support providers and patients in more of a group kind of setting.
Okay. In my location, because I've had some small grant-funded opportunities to experiment in primary care for the last few years, my docs have kind of gotten used to using me as someone that they contact after they've finished charting on the patient, maybe late in the day, through the electronic medical record, they'll just send me a note saying, this patient was upset in the office today, will you give her a call? Or, this patient has X, Y, or Z social problems. This person needs a referral to counseling. Will you help them with that? And, of course, that is usually a series of phone calls in terms of, trying to assess, does the patient really want to see a counselor, what's their experience been, and then just prompting and promoting and making several phone calls, actually, usually, because those things, as we all know, are not an easy fix. Going from being referred to a counselor to actually getting into one can be a time-consuming issue. So there's that I had been doing, and I'm having to kind of break free of that and really try to promote and get people used to the idea they can call me, really, no kidding, at the moment, at the time of service, and draw me in. Now, part of this is overcome by the fact that I have a cell phone, and other than this hour when I've actually turned it off, I typically answer it every time it rings, no matter who calls me. And patients and others are used to me taking a brief break from whatever else I'm doing to at least assess whether or not this is something that needs to be set up or it's a true crisis that requires me to step outside of whatever it is I'm doing. I'm working hard to get the huddle, which is beginning to be used around here, for the MOAs to help prompt the docs when they're thinking about the patients that are coming in, and they're especially planning on the challenging ones that they know are in the practice and are coming in again today, to think Jackie might be of some use to work some, to start something, in a new direction, or to, get some additional input on, because so often there's a real stalemate. So we're working towards the huddle. I also really rely on having good relationships with the medical assistants so that they see my face, they've got my cards at their desk, and I'm constantly kind of moving through their space to remind them I'm here and I'm ready to help. Let's see.
Hi there, it's Kate. I'm just going to jump in because there was a question for Brian, and I thought maybe we could just take it now since we're sort of at this spot. You alluded to documenting the impact of integration at the clinic level at Rosewood. There were some questions. If you could just talk briefly about how you did that and what measures you used. There was a question about that.
Yeah, definitely. What we use the PHQ-9, the GAD-7, and the functional scale. And so we put it on one page. It's in Spanish and English. It's double-sided. And what we do is we will provide that screening tool to each patient. And then every time the provider has a warm handoff for me, I ask that they drop that too. And what we've been doing is kind of documenting that data. And I think Brian Sandoval can speak more to this since he's been running the numbers. But he's been able to run some stats on them and present the data and show our efficacy that way.
Yeah, I can speak a little bit to it. Basically, when you look at the three measures, anxiety, depression, and functionality, we've started, as Brian Chow said, we started implementing that in the workflow, and the data shows that, while we see a lot of patients just once, when we see patients to come back for a follow-up, when we look at our data, about 80% of patients show improvement from visit 1, from baseline to visit 2, in one of the three measures. So right away, we're seeing an impact, and an impact right at the first visit. So, and it's really interesting to see over time as we look at the data, and we started to notice too that not only are we seeing that visit 1 to visit 2, but we're seeing that these outcomes are sustained over visit 3 and visit 4 if we see them at that many visits.
I'll just add in too that with other measures such as the Duke Health Profile, which looks at quality of life rather than symptom reduction, we see improvements by most people. And these are in very large studies and average of about 2.3 visits per patient. Most people are improving, which speaks to the importance of seeing people at the time of request at the time of need. So at this point, I think in order to cover the rest of our topic for today, I'm going to just move forward and ask you for a minute to think about why do we need to be brief in healthcare, and what are the benefits of being brief? And if you have ideas, go ahead and type them in, and we'll look at them real quick. Okay. So people are probably typing and thinking through and discussing, but in the name of being brief, I'm just going to go ahead and give you some of my ideas. Oh, Jackie says always available. Next patient coming in. So, we're getting at that concept of if we're not brief, we miss patients. And we know.
Oh, sorry, we have a couple folks writing in today. You can impact the greatest number of patients in a day. Primary care is typically high-volume service industry. Be brief so you don't overwhelm a patient with too much information. Another person shared that it helps to keep providers on time.
Excellent. Excellent. Those are covering a lot of the things that I was going to mention. We'd have way too many patients to not be brief, and we have way too few providers to not be brief. I think by 2015 we'll be short 25,000 PCCs in the country, and we're short on BHCs and RNs as well. We're short on space. We have too few rooms and limited reimbursement. And other people were talking about patient preference. So what do patients want? They want help when they want it, and they want help with the problem that they are concerned about, and they want interventions that fit with their worldview. And people don't have a lot of time, and they want us to plan with them in brief visits that in ways that use their strengths and their abilities and help them move towards clear action steps. And what I don't have on the slide that is equally true is the science behind being brief. Patients don't check with us to see whether or not to follow up. They just decide not to follow up or not to come for a scheduled appointment. And there is really no evidence that being not brief or having, for example, hour-long visits produces any better outcomes than the brief visits characteristic of the primary care behavioral health model. Oops. So you have hopefully printed out the PCBH Brief Competencies tool, and I gave it the name BICAT. I thought it was kind of sexy, and that it would catch on. If things like PHQ can catch on, BICAT should even be more popular. What do you think? Ha ha ha. Anyway, so remember it. It's BICAT, and it has 4 domains: primary care, intervention design, intervention delivery, and outcome-based practice. So these are 4 domains that are very important. And as you know, competency means adequacy or possession of required skill, knowledge, qualification, or capacity. So we can assess this through kind of content evaluations, and we can also use this tool like an evaluation of our skills in simulated and real-world practice, because some of these competencies are really about not just knowing it, but doing it, and you'll see as I go through them. So you have a chance as we go through them to kind of rate yourself. 1 is low. No shame in being low. Just know where you are. Some of these things are new, brand new. 2 is adequate, and 3 is exceptional. So what I'm going to do as I go through these areas in these 21 items is I'm just going to point out what exceptional might look like. So domain 1, the primary care context. We always want to make the most of our contexts. So number 1 is understanding the most common problems of clients in your promoting access to your service. So exceptional competence here would be like routinely using your data to know what are the top 5 problems of clients in your setting, and what can you do to market your services to these clients. Next is to address barriers to client access. So you got to understand what is getting in the way of clients accessing your service when they need it. So again, surveys might be useful, and then you want to address them by minimizing stigma. And so you don't have like a class called depression class, you have a class called quality of life class or life satisfaction class, and where you locate your services are optimal. Yeah, even your hours of operation are probably changing or expanding at this point. Third is working to share your skills with other members of your team so they can support your interventions. So as behavioral health providers and as primary care providers, we kind of have to think through our discipline-specific language to communicate as clearly as possible as we work more and more in teams, and make an effort, behavioral health providers, to teach some of the more common interventions so that primary care clinicians can better support them. Jackie, you had a comment that when I talked to you about your BICAT scores in this area.
Well,
you've been working in this area.
I'm sitting here fumbling through a few papers, having misplaced my BICAT. So,
oh, okay.
You want to send that past me again?
Oh,
I'm hung up.
okay.
I'm hung up on that, so I just lost my brain.
Oh, no problem. Well, when we were talking, you said that you were going, that you were teaching social workers at your CCO some of the behavior change interventions you had learned in the foundation training.
Yes. We have here a care management team of social workers that have been working together for about 10 years, and a lot of the things that are true of social workers in terms of their traits, their skills and their problem solvers and their thinking in terms of function and quality of life, and so many of the things that behavioral health consultants are concerned about and wanting to know about their patients. They have kind of a natural affinity to a lot of those issues, including mental health issues. And so they have some specializing in those areas that are an easy kind of relationship with behavioral health change. So they understand motivation and change readiness and these sorts of things. So they've been very interested, and I've been sharing all of my materials with them. And the one that I'm going to present first to them is on using medication. And the reason I'm thinking in terms of that is because, as we know, that is such a huge area of concern in medicine that, we give these prescriptions, they're expensive, the patients need to take them or perhaps have some options about taking them, and give them the pills and they go away. And if we could, kind of anticipate that there might be some difficulties around them wanting, maybe there's ambivalence. And the BHC site has a really good one on using medication successfully in terms of talking with patients ahead of time about what their previous experiences have been, what their concerns about, what kind of side effects they believe they experienced in the past, maybe planning with them for how they might cope with some of those issues, why it might be important for them to take this medicine, or if they're not really ready to, and if they might like some help on other avenues rather than trying medications. And of course, then you can go into the depression or anxiety skills training. And so I thought that would be a good one because, it comes to all of us in so many ways that the patients aren't taking the medicines that we think they are. It's a huge medical issue and a huge wasted expense.
It is, and I'll just say that protocol that you're using, we tested in a research study, and we were able to get people up to 91% adherence using that protocol. So it's really quite powerful, which kind of leads me to another point, which is like really thinking through, do we even need to start patients on a medication, and can we try behavioral interventions first? Because most people really want to change their behavior, and that's a more sustainable kind of intervention. As we have more behavioral health providers in primary care, we can offer that more to patients before we even consider starting the medication. At any rate, moving on
it's far more empowering to the patient as well, and it also sets up the relationship of, this is something you're working on, and I and we as a team can help you with that. Medicine is kind of here and gone. We'll see you in 6 months.
Yeah, exactly. Yeah, so to get the skills out there. So the next domain is defining the demands of the practice setting and making necessary adjustments to the practice. So that's kind of like, that would be moving towards the PCBH model because we know about 70% of the people coming to primary care do have behavioral health concerns. So we wouldn't want to use our precious behavioral health resource for 1-hour visits, but we would want to shorten our times. Moving to the second domain, and this is the big domain, I call it the Big 10, and this has to do with intervention design. So if we're going to work in 30-minute units, we really need to be thinking about how do we design our intervention to make it powerful. So the first thing is an introduction, and I think Brian was mentioning this. It's really important to introduce yourself in a way that says to the patient that you're going to help them in 15 minutes. You're going to get a picture of what's going on. You're going to make some recommendations. You're going to help them develop a plan, and that it's possible that the patient may take that plan, run with it, and not need to come back to see you. This is the case because about half the times, patients don't come back. And yet when we call these patients to find out, hey, how are you doing? Did you improve? They do most of the time. So including that in our introduction, I think, helps us capitalize on that potential. Identifying a target problem of concern to the patient at the time of the visit, really rather than going wide, go narrow. If you can help the patient with the problem that they're concerned about, it spreads out. It increases their sense of competence or their sense of efficacy of being a problem solver and being able to solve the challenges in their life. Using strengths in the intervention are very important, and normalizing number 4, the patient's problem, and avoiding pathology explanations of the problem. Certainly we can be aware of a patient's diagnosis, we can use it in billing, but I think we gain a lot in terms of working briefly if we can say things like, well, the problems you're having make sense in terms of your life situation right now. Very empowering for patients. I love this, baby steps. Number 5, focus on small changes, one step at a time. Use that phrase with patients. And 6, frame the intervention as an experiment to see what happens. This creates permission to fail. Failing is a good thing because it gives you information about whether that step or that plan or that intervention is the right one at that time for the patient. So very important to get that into the intervention design on a regular basis. These things are things that we want to do every visit, every time in a consistent way to maximize the impact of our brief interventions. Number 7 is to identify and address barriers to patient follow-through. Many times we can do this in the initial visit. We certainly can do it in our follow-up visits. And number 8, so important to ask the patient once we come up with a list of action steps, how confident are you in following through with this plan? 0, not at all. 10, very confident. We need to know. It helps us become better brief interventionists if we ask this question correctly every time. Number 9, at follow-up, encourage the patient to take ownership of behavior changes. So when the patient returns and they say, well, I did this, but I also did that, then, and it had a positive impact, then it's not about that, hey, you did what I said. It's about, hey, you're amazing. How did you get yourself to do that? And, how will you remember to do that in the future? And what else did you do? And that worked too. So you're coming up with new stuff. And one more, I think, on intervention design. Get myself moving forward. Oh, yeah. When it goes, it goes. Okay. Oh, no, I guess that's it. So domain 3, intervention delivery. So this is getting at what Brian was talking about. Really, we need pathways or routine procedures for consistent delivery of acceptable, effective interventions for common problems. This is going to help us so much with access, help us so much with really getting evidence-based treatments out there. It's a hard thing to do, and most people don't have high levels of competence in this. This is not clinical practice guidelines. This is like working with your teammates and saying, this is what we're doing, this is what we're getting out of our efforts to address this population. And these are the things we could do to improve care. These are the resources we have, and really matching resources to evidence and getting started. It's probably 5 things you could do to improve your work with any specific population. Choose 1 or 2, but try to get that consistency and measure outcomes. Number 2 is offering groups or to patients or clients to enhance their access for skill practice. I have been thinking a lot about this, and you see the example of the big group, behavior improvement group for parents with children age 6 and under as an example. I think we would be wise to always link our groups and classes in primary care to pathways. So domain 4 is kind of going after that scientist practitioner model and measuring outcomes. So using outcomes tailored to assess brief interventions would include high competence would be like using a problem severity rating question at every visit, initial and follow-up. So it might be a question like, to what extent is parenting your son a problem for you now that he's 14 and really pushing back on a lot of things? 0 to 10. 10 is a very big problem. This helps you kind of get an idea of the psychological distress, which converts to motivation for trying something new, and also to the impact of the plan when the patient returns for follow-up. 2, to demonstrate willingness and ability to change interventions based on assessment results. So that's back to that confidence question. When you get a response of 6 or lower, high confidence responding is like, wow, okay, we need to adjust our plan. Let's think through what we could change so that your confidence is greater. And being able to jump right in and change that so that there's a greater likelihood of the patient succeeding. And then the third and last item is using outcomes in aggregate to evaluate the effectiveness of your practice. I recommend the client's mental health or health-related quality of life scores at initial and follow-up visits. In primary care, really the measure that is appropriate for every patient we see, whether they're seen by a behavioral health consultant or not, is a measure of their health-related quality of life. And this kind of, is something near and dear to me, is how we define health. And for years, who has said it's the absence of disease, blah, blah, blah. But we know that really isn't a definition that really helps us figure out our relationship with patients, because we can't make disease go away. I mean, we're perfect at 18, and then it's a matter of how steep the slope is in terms of our decline. But what we can maintain throughout our life is our health-related quality of life. So in the primary care behavioral health model, I recommend that you use the Duke Health Profile. It's something that can be administered in about 3 minutes. It yields scores on mental health, physical health, and social health. They range from 0 to 100. They can be entered into the electronic health record in aggregate, and they can be used clinically to assess progress, but they can be used in aggregate to help you see how well am I doing with, for example, patients with diabetes. Is their social health improving? Is their mental health or their physical health? So yeah, we got started with the PHQ-9 and the GAD-7, and those are good instruments, but to my way of thinking, those are follow-up instruments when you need something more specific for a patient that actually is anxious or depressed, whereas the Duke Health Profile is appropriate for every patient referred to a behavioral health consultant and meaningful over the lifespan. So that being said, what I'd like you to do is go ahead and type in questions you might have and comments, as I just encourage you to develop a career plan based on your assessment on the BICAP. So maybe you can highlight or circle 1, 2, or 3 items that you want to get better in. Think about, who do you know that is a little better than you in these areas? Make a note of them. And then also think about who cares about your career. The person who cares about your career is somebody you're going to trust, and that's somebody that'll check in with you and support you over time. It's really quite difficult to change our practice habits, and we need to rely on each other. And it may be that some of the people sitting in the room with you are strong in areas you're not, and you're strong in areas they are not. So learn from each other and get better. At this point, I'll go to questions.
Hi, everyone. It's Kate. I'll just remind you, you can use the questions pane on your GoToWebinar control panel. You can send those in, and I will ask Patty to clarify. One that we got earlier was Brian, and Brian, if you're still out there, if you could talk a little bit about how you do measurement and use those measurements at the clinic level. The person who asked that question originally thought if you could talk about how you look at that clinic-wide, that would be really helpful.
Oh, so I can jump in a little bit and talk a little bit. One of the things that we just try to make sure and do is include behavioral health-related instruments in the workflow and the daily workflow of our providers, and then especially when they're going to be seeing behavioral health consultants. One of the things that Patty pointed out, which is really important, is if you're just measuring symptoms, you're missing part of the boat. in terms of really understanding how your program is functioning. And because a lot of what we're doing in primary care behavioral health is enhancing quality of life and functionality. So the functional scale that we included, along with the PHQ-9 and the GAD-7, is a measure of the ORS, or the outcome rating scale, a variation of that. And what we found is when we've implemented that measure and looking at the data, is a lot of times functionality improves before symptom reduction happens. So symptom reduction is a byproduct of improved functionality, and that is consistent with the acceptance and commitment therapy interventions that we use, the brief ones in primary care. So basically, we've started about a year ago collecting data on these three measures just to see how they relate to each other. And we started that in terms of, again, implementing that into the normal workflow for all of our clinics, and then re-administering that tool at baseline, or administering it at baseline and then re-administering that tool at follow-up, and then looking at the differences. One of the things you want to look at when you think about data collection for like a PHQ or a GAD-7 is a score of 18 on a PHQ, or might be really high for somebody, and it might be a little bit lower for somebody else. So you want to look at measuring between our intra-patient scores. So the change in score pre and post will give you a better idea of how your program's functioning, rather than just looking at scores of individual patients and then trying to compare them. So at the end of the day, the pre-post measure has really given us some insight in terms of how our program is going, and it's helped us understand that not only is symptom reduction important, but again, like Patty said, improving the functionality first and foremost and getting them functioning better usually leads to symptom reduction as a byproduct, and we've actually seen that in our data.
Yeah, it's just, I guess, 2 points, I would say, just in terms of working it into your workflow. And I've been working with the Air Force worldwide on this, and they've gone to the Duke Health Profile because it is normed on primary care, and the norms are age and gender specific, so you really, psychometrically, you can feel really confident about that. And the way that I train is for people to work it into their workflow. It comes immediately after the BHC provides the introduction. They ask the Duke questions, because many of the Duke questions are things that a BHC needs to know, in terms of social health, in terms of concentration. It covers quite a lot in the 17 items. And again, normed on primary care, appropriate from 18 and over, and very easy to work into the workflow of the visit. And docs like it. Scores 0 to 100. It's like, what did you want on your spelling test? So when I worked at Farm Workers, I had the experience that a number of our primary care clinicians started using the Duke in their follow-up visits and in their initial as well. And it was funny, they called the Pediatric Symptom Checklist 17 the Kitty Duke. Very friendly and meaningful, outcomes.
Hi, Patty. We have a couple more questions, and we have about 1 or 2 more minutes, because I know people probably have to get off to their morning at 9 a.m. So one person shared that part of the struggle they're having as a BHC is how to encourage and promote same-day warm handoff with the primary care clinicians. They support the idea, but somehow in practice it's a challenge. Instead of a warm handoff, they send the patient to the front desk to schedule, and often patients leave without being seen. So I don't know if Brian or Jackie, or really, really quickly, you wanted to jump in on anything you've done to help with that problem?
It's really important to, I would just say, to have your scheduling system set up so that the BHC can immediately put the person into the schedule because they need to have an encounter so they can chart in most electronic health records. So it's training the BHC or getting support from medical assistants in terms of entering the patient into the schedule for the BHC. So it's training.
One of the things that I think is really important in the situation that's been described, this is Brian Sandoval, is visibility. So in order to really maximize and start to develop a same-day workflow handoff, you really have to be right there, right next to where the primary care providers are providing their care. So then you're not, you're right in their face. You're right there as somebody they can grab and pull in. So being location is something that's stressed in real estate, and I can't tell you how important it is in behavioral health consultation. Putting yourself right next to where the primary care providers are at and making sure you're easily accessible really makes or breaks your program. And we actually noticed that in our Rosewood. We relocated the behavioral health consultant to sit right in the same kind of pod area as the other primary care providers, and it grows organically when you do that and you're present.
That is so important, and other things like Jackie said, you know, like going to the huddles so they can anticipate when they're going to pull you in, but you also have to look at the details and the barriers in terms of PCCs being able to see the BHC schedule. And I tell you, some of the greatest workarounds are technology in terms of, you know, like instant messaging, BHCs, hey, need you in room 221. Just
all right.
like that. Yeah.
I don't want to cut you guys off. I know this is a great conversation. There were a couple of questions we didn't get to, and we'll follow up with those folks via email. I want to thank everyone for joining us today, particularly Dr. Robinson and our guest presenters, Brian, Jackie. Thank you so much for your time this morning. And thanks to everyone who joined us on the line, both for your attention and your insightful questions. When the webinar concludes, there'll be a short survey. Please complete that. It helps us improve webinars in the future. We really value your feedback. Thanks again, and Happy New Year to everyone.
Thank you.
Thank you. Bye.
Thank you.
Happy